and I would like to share with you. Can you turn on louder to wake everybody, please? A little bit more. Thank you. So, since Homely Wang talked about the third dimension, I wanted to change it a little bit and talked about the fourth dimension to make it more interesting. So we will not go home. So, let's see. What is aesthetic? Nobody talked about aesthetic. Well, I never saw a crown like this during the day. Those people pay a lot of money to get these aesthetic results. What is aesthetic, guys? Who defines aesthetic? The patient? The doctor, his girlfriend, his wife. Let's see what is aesthetic. I'll show you even more. This is not aesthetic. This is the same guy a few months later. He did a crown lengthening, veneering. It is a period in the States, we call it multi-veneering. So every patient who comes in goes home with a lot of veneers. But the question is, who defined aesthetic? Is the doctor? Do we have parameters? I saw a few cases today without papillas, and the lecturer said, look at this beautiful case. I know Andres Sadoun, he's a guy from France. He will start treating the patient in these cases when somebody said, beautiful case, he will start to build the papillas. So what does it mean, aesthetic? What does it mean, perfect aesthetic? Is this perfect aesthetic? So this is my favorite patient. He has a low lip line. He pays in advance, and he looks great, with or without teeth. Now let's go back to reality. What is dentistry today? So dentistry, first of all, is evidence-based. So we should stay on evidence-based facts. When somebody talks about papillas, about soft tissue thickness, about implant position, we have multi-center studies. This is what should be the fundament of our daily work. The second level in dentistry is practice-based. Every single one in the room has his own experience, and you have individual methods you use since years, 10, 20, 40, 50 years, with success. It's not been published, but you are successful with it, so keep it. Don't change it. The lowest level in dentistry is opinion-based. A guy comes on the podium, he shows you put a bridge on 3 implants. We call it all on 3 instead of all on 4. Or we call it all on 1. Do you believe me? If I'm a nice guy, maybe you'll believe me, you'll do it. So you have to understand that there are a lot of opinion-based which are not working. They work only in one hand, in one office. They will not work in every office. So we have to be very open and very fair, and this opinion-based stuff, to try it in very small cases maybe, and to look later on to get practice-based and then to have the evidence-based theory. But you have to understand there are a lot of techniques which may be excellent in the hands of some specialists, but if somebody will take it home, he will not be so successful. So we will have to find solutions. Well, we will talk in the next 40 minutes, 50 minutes, 2 hours about fundamental of aesthetics. We'll talk about aesthetic complications, and I'll try to give you some solutions. So let's talk about fundamentals. What is fundamental of aesthetic? Well, the patient expectations, they would like long-lasting, predictable aesthetic result. We saw the beautiful cases for Dr. Sadeh. He showed cases that were beautiful for 2 or 3 years, but 5 to 6 years later, I think that none of us would like to have these cases in his office. I don't know what to do with a case like this. Somebody with a beautiful crown come to my office and will tell me, well, can you make a graft or make a new crown or remove the implant after 6, 7 years? So we need long-term, predictable aesthetic. Functional, of course. We try to do it minimally invasive. Well, when I listened to Dr. Ormiana's presentation, he's an excellent prosthodontist. He said, well, because I'm a prosthodontist, I'm not opening a flap. The perio guy, Homely Wang, will always open a flap. Now, somebody told me if I open a flap, I lose bone. So what should I do? I open a flap or not opening a flap? It's very embarrassing. And then the subjective comfort, minimum risk, minimum complication, and optimum cost effectiveness. So let's see the fundamental of aesthetic described by Maniers. Gingival health, interdental contact, tooth axis, gingival level, gingival zenith, and then it's going to interdental contact level, tooth relative dimensions, basic characteristics. The surface texture, sometimes the shade will be very important for us. The incisional border configuration, the smile symmetry, the facial symmetry, and the lower lip line. So, if we decide that perfect aesthetic means papilla at the same level as at a natural tooth, I can tell you officially, I'm 30 years in the implant field and I inserted 25,000 implants. I never got the same level of the papilla as at a natural tooth. And I will show you excellent cases, but we always lose 0.5 millimeter. This is the reality. We cannot change it because of the surgery, because we have different ligaments. So then we will have to know the proportion. We have to know the width of the central and of the lateral. Now, if I understand correctly the lecture of today, we need 1.5 to 2 millimeters distance to adjacent teeth. Is correct? Raise your hand. Maybe I did not understand. How much? 2 millimeters to adjacent teeth. 1.5. When I have a lateral incisor, it's 6 millimeters wide. And I have 1.5 and 1.5 on each side, or 2 millimeters. I don't have a space for a 3.8 millimeter implant. So how do I treat this patient? So we need to find solutions. Maybe I use small diameter implant. Maybe this is the solution. And then we will have to know the proportion between the width and the height of the crown, and to define really the perfect aesthetic. This is perfect aesthetic. If I have the zenith of the crown here, it's a nice aesthetic, but it's not a perfect aesthetic. If I have the lateral and I have the height of the soft tissue here, it's a nice aesthetic, but not perfect. And if I would like to have a nice symmetry between both canines, I need exactly this level and this proportion, 7.5 millimeters height and width. So the 1.6, 18 millimeters, those are the proportion. And in order to find out the exact position of the implants, I think that it is very important to share with you, we need a surgical guide. We need a wax up. We need a protocol. I cannot put the implant at a perfect position. And then the selection of the implant diameter is based upon the anticipation and location of the fixture. And if I have a small diameter and everybody goes in this direction, it means that I'm going to have more bone around my implant, and it will be a long-term success. Sometimes we lose bone buccally because we don't keep the 2 millimeters width. So this is our workflow. We make an aesthetic analysis, we make a functional diagnostic, we make a mock-up and a backward planning. I'm missing in some cases the backward planning. I don't know where to put the implant. Somebody has to show it to me. We need to decide which reconstruction we're going to do: bone, soft tissue, implant, abutment design, and the tooth on the top of it. I'd like to know it in advance, and I need a provisional. I will never get a perfect result without a long-term provisional crown, and then the final reconstruction. So the aesthetic analysis and the backward planning are, for me, the most important criteria for us today in the daily practice if we talk about aesthetic. None of us can put implant in the perfect position without a backward planning concept. And then we have to decide also which parameter we keep and which parameter we change. Sometimes we will have to change the soft tissue environment. So the smile, in most of our cases, 68.9% for our patients, they show between 75 and 100% of their teeth. This is a fact. So it means if you have 70% of your patients showing 100% or 75% of their teeth, we must do a perfect aesthetic reconstruction in advance to know the position of our implant. We have to evaluate the dentofacial story. We know the vertical dimension and the crown height. If I don't have 12 millimeters, I have more than 12 millimeters. This is one of the facts that I learned from Kalmish. I will never do a single crown. I know it will be complicated. I have to know between 8 and 12 millimeters, you can do a perfect aesthetic. Between 12 and 15, it's a compromised aesthetic. And more than 15, it's a very compromised aesthetic. So you will have to tell your patient which will be the best result. We have to decide sometimes to do a pink ceramic if we have a low lip line. But the question is, do we have a lot of patients with low lip line? Now, this is what I missed during the day. There are two articles or two parameters very important for us. It's pink aesthetic score and white aesthetic score. This should be actually the standard in aesthetic evaluation today. I want to know if the medial papilla is here between 0 and 2, the distal papilla, the curvature of the facial mucosa, the level of the facial mucosa, the root convexity, and then I can evaluate my aesthetic outcome, not say this is perfect aesthetic. Sometimes you are missing a papilla, so you will not get the 10. Same is with a crown, the tooth form, the outline volume, the color, the surface, and the translucency. So we will have, if we talk about aesthetic, to agree that we need some criteria. We need to evaluate the aesthetic, not verbal aesthetic, like look at this beautiful case. And then it's an article published by the University of Vienna, which defined the mesial papilla, the distal papilla, the height of the gingival margin, the contour, the texture, and the color of the gingiva. So now we compare between implant and teeth. They are completely different structure for many reasons. One side we have 2.04 biological width. That's what we think. On the other side, we have about 3 millimeters biological width with the sulcus, with the junctional epithelium, and with the connective tissue. But we will have to be very clear that the orientation of the ligaments is completely different around teeth than around the abutments. The connective tissue around the abutment has horizontal fibers and not vertical fibers. So when we know that we deal with a completely different situation, we will have to agree that we lose half millimeter of the papilla anyway. Now, looking at the soft tissue, we'll have to evaluate the bone. So this is the resorption pattern described by Atwood. So I try to put implants, if possible, as soon as possible after extraction. So I try to convince my patients. So now we know more or less the criteria, the fundamental aesthetics. And now let's see how can we get complications. You saw a lot of complications today. I'd like to summarize it. So we have complications because of implant diameter, too big diameters. We have a too buccal position, too deep position. We have lack of lateral and vertical bone augmentation. We need to respect the 2 millimeter bone fascially. We have to optimize the soft tissue. So as you saw today, some use connective tissue grafts, some use partial flap design, some use some synthetic material, some use human material from cadaver. And last but not least, the time. As I said, I'm confused. Immediate implant placement or maybe late placement. And the healing period. Sometimes after opening the flap and putting a temporary crown, we'll have to wait. And then we will have to evaluate our cases from the beginning to know exactly how can we get the same perfect result on the long run. The axis of the implant has been mentioned, no doubt. Now I need a safety zone because you saw very well that anatomy is very variable. So we have a danger zone of 1 to 1.5 millimeter to adjacent teeth, and we will have to respect it. The moment I don't get this distance, I'm not going to get a papilla, never ever. And it doesn't depend on the soft tissue biotype. You will never get a papilla. So you have to know it. Then we need to know that the buccal area need to have at least 2 millimeters. I will give you a suggestion. You should go to 2.5 millimeters because we're going to lose this 0.5 millimeter when you open a flap or even if you don't open a flap. So we will have to agree that we need 2 to 2.5 buccally and 1 to 1.5 minimum on both sides. 2 millimeters are even better. Now, looking at the implant position, there are a lot of possibilities. This should be the ideal position because we have a thick buccal plate. This is the thin one. We're going to lose about 3 to 4 millimeters buccally within a few years. And here, you're going to lose a little bit, a little bit. Now, this is in the aesthetic zone. You can say, well, the patient doesn't see it. The question is, did we respect all the criteria? The distance between the two implants is 0.5 millimeter. You cannot get a solution here. So we will have to decide where to put the implants. An aesthetic position implant with 0.5 millimeter to the distal and 2 millimeter to the mesial. The crestal bone resorption with gingival horizontal defect. Now, how can we repair a case like this? Removing the root, inserting the implant in the right position, and improving the soft tissue quality. How can we improve the soft tissue quality? We take a partial flap from the palatal area or from the tuberosity, and we insert it in this region. And this will be the final result. We have the papillas, we have the bone height, and we have a preserved restoration. This is after 3 years. Now, everybody mentioned the buccal position of the implants. The article of Evan showed us that if you put the implant to buccally, you're going to lose actually about 2 to 3 millimeters vertical bone height. And if you put the implant to the palate, you will lose 0.5 or 0.6 millimeter bone height. So we have to agree that the immediate implant method requires very careful case selection and high surgical skill level if the aesthetic outcome are to be achieved. Now, what we learn is rich preservation. It has been mentioned by all the former speakers today. I will not go into it, but I will mention and I will show you the bone regeneration around the implants, the day of surgery. What happened the day of surgery? This is the implant surface. This is the implant surface, this is the bone surface. In the first 4 to 7 days, we have a mechanical initial stability. And then we have a connection, a network, a collagen network, a fiber, which will connect the bone to the implant surface. But we still have just a mechanical stability. It has nothing to do with osseointegration. And it takes between 4 and 14 days. And after we have this network, this fiber network, the blood supply starts migrating from the bone to the implant surface. And the osteoblasts are moving from the bone to the implant surface. And the process of osseointegration begins. So if we want to do immediate, we have to do it in the first 3 to 4 days after implant placement. It is a must. Otherwise, we're going to lose the initial stability. And if we want to do final restoration, we have to wait between 10 and 16 weeks, at least. We never do a final restoration before 3 to 4 months because the biology is not there. And you can try to put whatever you want. The biology is not there. So this is the process of osseointegration. Now we can load our implants. Whatever you do before, you lose bone and you lose implant. So now in the last almost 10 minutes, I'll show you the solutions. What are the solutions? We need to use small diameter implant. We need to know the exact position of the implant. We have to make lateral, vertical augmentation to optimize the soft tissue and to choose the best time. So this is exactly the result we want to achieve with a beautiful frame. Now, we will have to know the bone volume. And if I measure the bone volume, we can do it with the probe, or we use a CT scan, because the CT scan gives me exactly the dimension I need. Scott, why are you standing? I have another 5 minutes. Oh, it become 10, look. So you will have to see the bone volume and to evaluate the aesthetic and functional outcome of your cases. The more information about bone you have, the better will be the result. But now look at the interproximal papilla, published by Lars Schropp. He showed that after 1.5 years, after sitting the implant and the crown, it was no difference between the immediate placed implants and the long-term placed implant. So if you put the implant properly, you may end up later on with the same outcome. Of course, you will need to evaluate the bone volume around the implant position. You will have to evaluate the axis of your implant and to make what we call the 4D planning. What does it consist? First of all, I measure the soft tissue thickness at the implant position. I measure the buccal plate 2 millimeters, 7 millimeters between the implants, and I use a vertical position 3 to 4 millimeters below the CJ line. This is a case we published 1997 with natural teeth on implant. It was a malpractice lawyer, very famous malpractice lawyer in Germany. She had a motorcycle accident and everybody used composite to fix her teeth. Now she had a root resorption on both teeth and she wanted to have her own teeth stabilized in whatever method we want. And if she got complications, she's going to sue me. So actually the enemies sent her to my office. We used the natural crowns. We cut the natural crowns 3 millimeters below the CJ line. We adapted them to 2 peak abutments. You see the root resorption. We inserted 2 15-millimeter implants. We did a selection, and we reduced the diameter. Even at the time, we took 4.5 millimeter instead of 6.5 in a central socket. And then we did a vertical augmentation. We inserted both implants at the same level, regardless of the bone volume and the bone height. So this is after 5 weeks. This is after 18 months. Same crowns with a beautiful soft tissue, but with a black triangle. So we convinced her that we will do better with the final crowns. But look at the soft tissue adaptation around the natural crowns. Those are the final crowns. And this is the case 7 years later. Look at the height of the papilla. We lost about 0.5 millimeter in this area. And maybe 0.3 millimeters in the lateral area. But this is a long-term success. Now, talking about the biological width, it's an article from Vacek which showed that the biological width is like a fingerprint. It's between 0.75 and 4.33. So now, looking in the literature, we know that we cannot remove abutments. So what do? We insert our implants 1 millimeter below the bone at least. We need 3 millimeters between the implants, 2 millimeter buccal, 3 millimeter attached gingiva, and 3 millimeter soft tissue biotype. And this is the advantage of the platform switching. Now, putting an implant in an extraction socket, we have to know that we need to put it about 2 millimeters below the buccal plate and 2 millimeters within the alveolar socket. So this is the implant position. I need 2 minutes. This is the implant position depending on the soft tissue thickness. I have thin soft tissue, 2 millimeters. I have very thin soft tissue, about 3 millimeters below the CJ line. So single teeth, we try to prepare the abutment in advance. This is the extraction socket. We use the ice cone as described, but I eat the ice and I put just the cone. This is the final abutment prefabricated with a temporary crown, and this is the same case after 3 years with a final crown. So another important point is the diameter of my implants. Here I have about 5 millimeters. I need to reduce the diameter of my implants and make it minimally invasive. So we use the two-piece, a new implant, and put a temporary crown the same day. But I respect the distance between the adjacent teeth. Using small diameter implants give us the possibility to respect all the rules we mentioned during the day, 1.5 to 2 millimeters on each side. And after about 4 months, and I always wait 4 months, we remove the crown, we take a final impression, and we put the final crown on it. But you will have to wait a few months in order to get a full osseointegration and a perfect soft tissue regeneration. A single crown, it was an accident, and this is the point I was missing today. When we do immediate restoration on implants, I try in most of the cases not to use cementum. But when I use cementum, I make a hole on the temporary crown in order to get the surplus out, because we have 35% inflammation and bone loss because the cement go into the socket. So we will have to mention that either we use platform switching. This is a case we did about 9 years ago. We did platform switching at a time. But the temporary crown had a hole. This is the final abutment inserted the day of surgery after 4.5 months. This is the final crown 3 months after insertion. And this is 3 years after insertion. Of course, we lost a little bit of papilla. It was minimally invasive. Surgical guide, same case. I will go to the last case. Okay? So, I'd like to show you multiple implant case, so make it a little bit more interesting. You trust me that we put single implants. So, we restore the buccal plate. Sorry about that. It's what happened when you put a computer in the back. You see that? Okay. Concave, temporary crowns. Now, we do our 3D planning. We plan the bone volume. We plan in some cases as 3D blocks before we start the surgery. We remove the fixation screws 4 to 4.5 months and insert the implants, and we do everything digital today. So we plan the abutments, we plan the virtual crown, the virtual abutment, and the implant position. And then we send just our final abutment design to the lab. They can do it in PEEK, in titanium, or in zirconia, or with a metal core. It's a hot topic. We had some fractures of these beautiful abutments. I don't want to go into it. And then we make the 3D planning, implant position. We prepare the surgical guide in advance. We prepare the final abutments in advance, and we prepare temporary crowns in advance. So we do the minimal invasive surgery. We can do it either with or without flap. We prefer the non-flap surgery, and this is the way the patient goes home. Now, the same case, upper jaw, we plan the 8 implants in the perfect position to avoid any aesthetic complications. We use the surgical guide to mark the bleeding points. Then we use a soft tissue punch to remove the soft tissue in the implant insertion. We use the guide for the pilot drilling, and we insert the implants. We have a prefabricated bridge in advance with reduced occlusion, and this is the way the patient goes home, and they have no bleeding. We have an aesthetic outcome. This is after 3 months. Thank you very much for your attention, and thank you very much for the 2 minutes you gave me.